It's really a great thrill to introduce Dr. James Ellison, the new director of the Swank Memory Center here at Christiana. He's from Minneapolis originally. He went to Harvard College and then went to medical school at UCSF. Came back to Boston, trained as Mass General in psychiatry, and has been in Boston until he came and joined us. He wound up due south, came to Delaware. He was first on the faculty at Tufts, my alma mater, and then returned up to Harvard. He's had all kinds of posts and done all kinds of things. I can't keep them all straight, but he's been head of geriatric psychiatry at McLean Hospital, among many other things. He also has an extensive publication track record, including both manuscripts and book chapters, and has had many research grants. I've had a delightful conversation on this very subject, since neither of us are exactly, say, adolescents. Right. But you see, I remember it, so both our memories are fine, and now we're going to hear all about it. Jim, thanks.
Thank you. And thank you all for making the time to come and listen to this talk today. I'm pleased to be here. This is a topic of importance to me, not just because I'm an aging physician myself, but all of us face in one way or another the question about how age is going to affect us and affect our practice. I want to start by saying that we've all had the experience of being mentored, taught, inspired by our older colleagues, and that older physicians are a very important part of our education and part of our healthcare delivery system. And as you'll see, physicians over age 55 make up the majority of the healthcare system at this point. But we also, many of us have had the experience of seeing physicians who practiced beyond their prime and even to the point where there were some deleterious consequences. I'd like to just take a show of hands. Has anybody had the experience of knowing of a colleague who suffered from cognitive difficulties and continued to practice? No. So a handful of people. And some of us have had the experience of being unwilling to do anything about that situation. Many physicians feel that somebody else will take care of it, or that it's not a big problem, but it actually has been a problem for physicians and patients. On the other side of this is the important protection of patients, of physicians' rights, because as people who devote our careers to practicing medicine, it's very important that we find a way to end our careers gracefully, with dignity, with honor, and some programs that have started to evaluate physicians risk infringing on that. That's why I used this logo here, which has a caduceus along with the scale of justice. Okay, good. One of the very famous cases of a physician who was very eminent and practiced beyond his prime was Dr. Ernst Sauerbrook. Many of you may have heard about his innovations in thoracic surgery. He was very well known for that. He was honored personally by Hitler. He was in Germany during World War II. And in fact would have received the Nobel Prize if Hitler hadn't decided that the Nobel Prize was not an appropriate prize for his country. He invented a special prize for Dr. Sauerbrook. Anyway, as Dr. Sauerbrook aged, he developed vascular dementia, and he's said to have operated in his own kitchen, used no anesthesia, sewed people up with sewing needles, and done other things that were really horrendous. This was a situation where nobody wanted to interfere with him because of his eminence. Very extreme case. In my own experience recently, and I'm going to disguise the details to protect the anonymity of my colleague, but one of my colleagues in another hospital had the experience of aging into some cognitive impairment. And this became noticeable to colleagues who saw that he sent patients with very confusing histories, sometimes mixing up the details of one patient with another patient, with some very bad results. One patient, for example, receiving a diagnosis that was serious and also incorrect. The physician in question had his own primary care doctor who decided that he had to do something about this and contacted the medical society, and the physician was taken out of practice rather abruptly. The consequence was a serious depression, almost a suicidal risk, as he came to terms with this abrupt, unwanted change in his professional life. And over time, things have straightened out. What I'm going to talk about today is going to give an overview that'll include some of the issues that come up in cases like this. We're going to talk about the cognitive functions that are affected by normal aging and talk about the difference between normative and pathological aging. I'm going to talk about how changes in cognition associated with aging affect medical practice and the research about that. I'll talk about programs that are model programs in the United States and also some of the ways that other countries have tackled the problem of making sure that the physician workforce is healthy cognitively. As you may know, many programs are already available to deal with physicians who are substance abusers or physicians who cross boundaries and have ethical violations or who are argumentative in the workplace and so on. But we're only just starting to see programs that deal well and appropriately and helpfully with the problem of cognitive impairment. And so I'll talk about some of the ethical implications of that. So let me talk first about normal cognitive aging and say that it's very typical as we get older to experience some difficulties with cognition. People in this room who are over 30 probably occasionally have to struggle for a name when you run into somebody that you haven't seen for a while. You may even have the experience of walking into a room and realizing that you don't know why you went there. That's a problem with prospective memory that sometimes occurs. There are a number of little slips of memory that are very common as we get older, and these shouldn't be cause for alarm, although they represent brain aging. Cognitive aging is highly individualized, and there are people who get older without aging cognitively in any appreciative way. It's estimated that perhaps 25% of 80-year-olds function as they might have 2 decades earlier. But the other 75% show some changes associated with aging. Cognitive aging is individualized, and some cognitive functions even improve with age. So, for example, we know of authors like Nabokov, who wrote some of his greatest work in his 70s. We know of artists, architects like Frank Lloyd Wright, who was creating the Guggenheim, I think up until his 90th birthday. There are examples of people who improve in vocabulary, in verbal expression, in passion, in the ability to understand, and what we call wisdom is one of the advantages of aging. Now, the neuropsychologists might talk about wisdom as a matter of crystallized intelligence, the ability to recognize patterns that have been encountered previously, and to know what to do because they've understood the consequences of various courses of action in that situation. Some cognitive functions that are particularly prone to change with aging are these 5, and that's processing speed, inhibitory control, working memory, long-term memory, and sensory perception. I'm going to talk about each of those first. Processing speed may be the most important for many of us. Processing speed is the rapidity with which we can learn new information, and that can drive many of the other cognitive functions. For example, it's postulated that working memory, which is the ability to hold and manipulate information in mind for the purpose often of problem solving or dealing with a situation that requires the juggling of multiple pieces of information, may depend on processing speed because information has to be kept in mind in order to be manipulated, and it has to be processed in order to be kept in mind. We test processing speed with timed tests such as trail making, A and B, where you connect numbers and letters, alternating numbers and letters, or the Stroop test, where you have to read a word that's written in one color ink and says the name of another color, and you read the name of the color ink rather than the word itself. And changes in processing speed have a basis in neurophysiology that's been identified with neuroimaging findings, such as changes in white matter, that can be seen even when there is no gross atrophy or visible lesion through a regular MRI, but diffusion tensor imaging will show microstructural changes in the white matter. Working memory, as I said, is the capacity to hold information in mind and manipulate it. When you look up a telephone number and carry it to the telephone, that's one kind of working memory, but there are more intensive forms of it when, for example, you do a test called an N-back test. You hear a string of numbers, and at any point you may have to produce the number that actually what you do is you indicate when the number that you're seeing now matches the number that came just before. So that ability to process the information that you're holding in mind. And that's a prefrontal cortex function. In other words, the part of our brain that helps us organize and use executive function. Working memory is considered in some ways an example of executive function as much of memory. Long-term memory or storage is relatively well preserved with normal aging, but there are some changes, and that's associated with regional findings, again, of reduced activation in the frontal lobes, in the left inferior prefrontal regions, and some other areas. And inhibitory control is the capacity to keep on track, and we all recognize sometimes as people get older, they can be more tangential, and they can get off track. So the way that we test that would be using distractor cues during a retention interval. So, for example, presenting somebody with a list of 10 words to remember, and then a list of 10 other words not to remember, and then having them recall the first 10 words. And that can be very difficult. Now, there's a lot of literature about whether sensory perception, yes, we're not going to do those tests. There's a literature about sensory perception and whether changes in vision and hearing affect cognition. And for example, if we think about the older person who needs a hearing aid and doesn't use it and is not as able to participate in conversations or get all the information that comes in, there's a question about whether that affects cognition, time, or visual input. But in fact, it turns out that hearing aids and or cataract surgery don't reliably improve cognitive performance. And that's given rise to another theory, which is that perhaps sensory changes and cognitive changes are really both manifestations of something more primary, changes in the central nervous system. Okay, so even these normal cognitive aging changes do reflect physical aging of the brain. And that's manifested by deposition of amyloid protein, which we see as a hallmark of Alzheimer's disease, atrophy, white matter deterioration, and changes in dopamine receptor number. And the brain compensates in a number of interesting ways. For example, by recruiting additional circuits. So the older brain makes use of all of its resources and de-differentiates the different functions of the right and left hemisphere that we see in younger people. This is called Herald, or hemispheric asymmetry reduction in older adults. And basically, the brain functions like a team that recruits more players as needed to make up for the shortcomings of the players that are already there, I guess, the way of saying it. If you take a look at an older person's brain under normal circumstances doing a difficult task, what you can see is that at a lower cognitive stress level, more of the brain is more active. And that's evidence that the brain is actually working harder. There have been some studies that have shown that cognitive training actually reduces that overwork and makes the brain function like a younger brain. But also, as the task gets more and more difficult, the brain kind of poops out, and you see a hypoactivity, a hyperactivity. Testing. Okay. So now, I've talked about normal cognitive aging, and the next thing is to talk about what's pathological. And we all know this clinically. We see people who are compromised in their ability to function independently. And once independence is really impaired, that's dementia. If it's not a reversible delirium or caused by some medication, substance abuse, some of the medical problems that we see that cause reversible cognitive changes. But we can start with what would be called subjective cognitive impairment at the beginning of the pathological cognitive aging. Subjective cognitive impairment is a relatively new idea. Before 1980, there was no literature on this, but now we see a couple thousand citations in the PubMed, let's say, that talk about this idea of people who are concerned that they have cognitive difficulties that go beyond what's normal, and yet on cognitive testing they do pretty well, and their independence is not compromised, and they're doing okay. So subjective cognitive impairment, we're finding out, is linked with greater risk of developing more serious cognitive impairment, and with changes in amyloid deposition, and with PET scan metabolism in the temporoparietal area. So we see that there are some underlying physiologic substrates, even of subjective cognitive impairment. If somebody comes to the primary care physician and says that they're having significant memory problems, it already puts them in a higher risk group for developing dementia later on. However, the good news is that especially under 60, the person with subjective cognitive complaints often has a treatable anxiety or depression or medical condition that can be treated. So it's only as people get older that the subjective cognitive impairment becomes more of a concern in that way. Mild neurocognitive disorder is the term that now replaces what used to be called mild cognitive impairment. And as originally defined, talked about a person who has a complaint about their cognitive functioning, or somebody else has a complaint about their functioning if they're unaware of it, and it's demonstrable by neuropsychological testing. Now, we call it mild neurocognitive disorder now since the 2015 or 14 publication of the DSM-5. And it's now codified in a different way, which makes a lot of sense. Mild neurocognitive disorder refers to somebody who requires workarounds or compensations in order to function at a normal level. So now they're dependent on their GPS to get even to some place they're familiar with, or they're more dependent on lists, reminders, and yet they manage pretty well. Most people wouldn't know that there's a problem. The reason we want to know about a person with mild neurocognitive disorder is because they definitely are at a higher risk to develop dementia. Some 15% of them will go on each year to develop Alzheimer's if they fall into the more memory disordered group. Impairment. The boundary between mild neurocognitive disorder and major neurocognitive disorder, which is the new name for dementia, is crossed when independence is compromised and a person can't function without help. And the DSM is different in its new diagnosis of major neurocognitive disorder in that now it delineates 6 areas of cognition, and only one of them need be impaired sufficiently to interfere with independence. So possible to have a problem with executive function that's that severe that it interferes with independence without having a problem with memory, for example. And that's a good change in the DSM because it allows us to diagnose frontotemporal dementia at an earlier stage. Now, the average age of United States physicians with an active license was 50 in 2010, 51 in 2012, and 52 in 2014. And looked at in another way, what we can say is that the number of physicians who were practicing in the United States in 2014, there were 30.9% of the physician workforce was over 60. There are studies that have looked at age-associated cognitive decline in physicians. And I think, on the whole, the reviewers of this literature would say that it's very flawed. For example, just recently, something came out from the AMA citing a often cited study about how older physicians have been are more likely to be subject of a lawsuit or a complaint. And when you look at the data of that study, it turns out that, in fact, it's very confounded because these older physicians have been in practice longer. They've had more exposure. So it's really just a matter of more years rather than age, probably. And there are some confounds in the literature about this. But it's estimated that some 9 to 10% of physicians might be impaired. The real number is not known. And one of the best studies of this was done with a computerized test called MicroCog that's written up in a book called Profiles in Cognitive Aging by Powell and Whitla. And they talk about their group of physicians that they compared to a group of non-physician normal aging adults and found that there was a significant decline cognitively in both groups after age 60, but the physicians declined cognitively at a slower rate. This is thought to reflect the idea of cognitive reserve. All those years of study pay off in that way. But then after 75, they declined at the same rate. The kinds of skills that have been looked at for aging physicians include knowledge base, performance on exams, and certain kinds of practice like history taking, physical examination, record keeping, and so on. And in general, there are findings that these objective skills decrease with the number of years in practice. However, important to point out that age is not one of the most significant variables when you look at these kinds of things, and I'll talk about some of the others later. As we get older as physicians, we tend to rely a little bit less on thorough examination and more on faster pattern recognition. And this has both good and bad. Physicians who are experienced make a quicker diagnosis, and sometimes they pick up things that are missed by a different approach. But this is a often cited finding in older physicians that pattern recognition becomes a more important part of diagnosis. There's decreased working memory speed and inhibition of irrelevant information, and that's thought to be an interfering factor associated with age. And when there are problems with sensory perception, that adds to it. Now, it turns out that if you take a look at physicians who've been referred because of questions about their competency to a place like, this comes from the Colorado program, I think, what you find is that many of those people who've been referred for questions about competency do have cognitive difficulties. So it's kind of like a marker for the likelihood of increased cognitive difficulty. And this was one study that looked at that. Among physicians who were referred in a program in Australia, this was also true. Half of those who were referred for inappropriate prescribing or other infractions had cognitive difficulty. And this was found in the Physician Review and Enhancement Program in Ontario, Canada, where about 1/3 showed moderate to severe cognitive impairment. And again, in a study in California, microcog scores were lower in physicians who were referred because of competency questions. There are some programs that have taken tests like microcog and embedded it in a larger evaluation program. These programs tend to look, and this is good, at naturalistic practice issues like what's the environment of the practice, how many patients is the doctor seeing, what are the tasks that they're doing. Some of the studies, for example, show that certain kinds of complex procedures like endarterectomy show changes with, or coronary artery bypass is another one, show some deficit in skill developing on average, certainly not for every surgeon, over the number of years since beginning practice. In the United States, we have various approaches to dealing with physicians who may be cognitively impaired, but the fact of the matter is that there isn't an organized approach. Some CME activities are available, of course, to assess physician performance. But we all know that physician, you were asked a few questions about what I say today, it would indicate how well you listen to what I'm saying, but it wouldn't give a general assessment of your practice ability. And many CME activities don't have that. The maintenance of certification program has been buried in controversy, and some specialties are, tried to eliminate it and so on. But it does have some meaningful measures of ability. One of the problems with the MOC program that's often been brought up is that the medical profession is policing itself. And some critics of the program say that it would be better to have an objective observer rather than self-policing. And I was going to say that there are now some 50 hospitals in the United States that have programs to assess their older physicians cognitively and physically. So, for example, the University of Virginia has a program that they instituted in 2011 that requires physicians at age 70 to enroll and have every 2 years a physical and a cognitive test. And if they submit to the testing and pass it, that's great. They continue with their privileges. But they're also given an opportunity to be counseled out if they don't pass. And I understand the statistics are that they've tested 35 physicians and 28 have passed and 7 decided to leave practice as a result of that program. And that's a number that probably seems reasonable. Okay. So the United States, most places, relies on either voluntary self-reporting or complaints. And we all know that complaints from patients often reflect bad relationship with their physician as much or more than they reflect actual bad medical practice. So that a person can practice at a level that's subpar, but not go detected. For example, I think about my colleague whom I mentioned here. His patients adored him. And even when he was giving a wrong diagnosis, nobody wanted to pull the plug on his practice because he had helped so many people and was so revered. Okay. So waiting until physician complaints occur may be too late, too. We might miss an opportunity to help somebody at an earlier stage. In the United States, there are some testing services available, the main one being the post-licensure assessment system, and that's used by some of these model programs. And it uses computer-based case simulations that are keyed to the physician's type of practice. So one model program is not far from here, the Lifeguard program in Harrisburg, Pennsylvania. Has anybody had any exposure to that or experience referring to that? No. It sounds like a very good program. It's a comprehensive evaluation that's based on the PLAS practice-based exam. And in addition, there are neuropsychological assessment that's available, physical examination, independent medical exams, and standardized patients that give a physician an opportunity to demonstrate their area of competence and their ability to show their skills. The data that are gathered from that evaluation are subjected to a multidisciplinary assessment that also includes peer review information and evaluation of the physician's documentation. And then feedback is given to the physician. Now, some physicians choose voluntarily, for example, if there's been a complaint made against them, to go to such a program. And that's one route by which they get there. And then the other route, of course, is that the hospital that they work for or the medical board in the state where they work will refer them. Another program, and one of the first, is the Center for Personalized Education for Physicians in Denver. And that's a program that advertises itself as essentially the advocate and ally of the physician. Let us help you show your competence. There is a darker side to this as well. They advertise as they are there to resolve concerns of referring organizations, especially for isolated incidences or knowledge deficits. And they also offer training and rehabilitative type of services for physicians. And then there's a program in Texas that provides physical examination, cognitive screening, and a review of patient care with feedback from coworkers and colleagues. Now, the situation in Canada is somewhat different and is more proactive in certain of the provinces. So there are rules in Canada developed in 1993 by the Federation of Medical Regulatory Authorities that stipulate that the provinces each can decide their own approach. And so in Alberta and Quebec, there has been what they call a level 1 screening, which is all physicians are reviewed by patients and colleagues using satisfaction questionnaires and peer feedback. And some of the other provinces use a less intensive and less costly approach. So in Ontario, for example, physicians in practice for 5 years or more under the age of 70 are randomly selected on a periodic basis. But over 70, selection takes place every 5 years so that everybody is evaluated. Well, one of the questions that we need to think about when we're evaluating older physicians is who is really at risk. That's why I entitled the talk, Patients or Physicians Who's at Risk. Both groups are at risk. We want to protect patients from inappropriate medical and incompetent treatment and provide the best for them. At the same time, we want to protect the rights of people who have worked long and hard to be great physicians. So age-based testing of physicians in some ways is valid based on what we know about aging and cognition, but in other ways it has some ageist qualities to it because there are other factors that may be even more important. For example, this is the study, the 2005 study, linked disciplinary actions with length of time out of medical school. But this was really a very flawed study because it didn't control for the number of years of exposure during which complaints could have taken place. And here's a graph from one of these studies, and what you can see here, of a pointer pointed out here, is that when we get up to this area, it sure looks like there's an increase in complaints that's nonlinear. But the N has dropped so greatly that we're talking about an N of 35 here compared to an N of 14,000 there. So it's really a sample that isn't a fair sample. There also are studies that report no link between physician age and performance. But even these studies are flawed, and I would like to cite them, but they're also not great studies. One of the interesting ones, though, was a study of 10,408 Massachusetts physicians using quality assessment tools, and what they found was that the characteristics most closely associated with higher overall performance were female sex, board certification, and graduation from a domestic medical school. Of course, we're not going to institute mandatory testing of all male physicians. That wouldn't be very popular. But I do think that the point of board certification is a very important one because that is a measure of quality of education and practice. So some of the other factors that have been cited as linked strongly with quality of practice are that individuals in solo practice, in general practice, who practice beyond the scope of their training, lack board certification, international training, or male gender in another study. These are important. We're not at the point in our country where we're going to see mandatory testing of older physicians, although the American Medical Association has convened a task force that's studying this question to make a recommendation upon. And there is a lot of interest based on what's happening in these hospitals that have instituted such testing. But screening is costly, and as I said, age is not the best predictor of problems with practice. Peers have been unlikely to report, and individuals who are impaired often don't recognize their impairment, or if they do, they're unlikely to refer themselves, so that sometimes occurs. When we talk about subjective cognitive problems or even mild cognitive impairment, they're difficult to detect. And the tools that we have to look at cognitive impairment show a kind of a fuzzy boundary between mild and normal cognitive functioning, so that we get a lot of false positives and false negatives, and wouldn't want to inappropriately counsel somebody out of practice who was functioning well enough to continue. Also, physicians represent a cognitively more skilled group of individuals, and their performance on these cognitive tests is higher, so that we run into a ceiling effect that limits the sensitivity of these measures. I tested many physicians who, even though there was some cognitive impairment, they functioned perfectly normally on screening tests such as the Montreal Cognitive Assessment, which is not sensitive to a decline in a very high level of intellect. As I mentioned, there's underreporting. In one survey, 64% of physicians agreed with the idea that physician discompetence should be reported to a regulatory authority. But when it came to actually reporting, only about 2/3 of those who had experienced colleagues with cognitive difficulty had reported, and they generally said that somebody else would take care of it, or reporting wouldn't do anything. And yet there are other professions, and this is the part of it that really is not ageist, that there are other professions where it's recognized as a fact of the profession that at a certain point a person retires. Surgeons in Korea, I think, retire at 60. In this country, commercial air pilots must retire at 65, air traffic controllers at 56, FBI special agents and park rangers at 57. And it is permissible to test when age is a bona fide occupational qualification. So it may be in our future that we'll see this. One of the places that had a lot of misfortune in trying to institute a policy for testing was Stanford. At Stanford, a few years ago, the hospital tried to deal with the problem of aging physicians who might have cognitive impairment by instituting a policy that required them to get tested at age 75, I think also on a 2-year basis, 2 years. There was a thoracic surgeon, Dr. Stockdale, who organized a group of physicians who refused to participate. And the faculty senate voted this down as an ageist policy, and in fact, the cognitive testing was dropped. So there has to be buy-in by physicians in order, Dr. Stockdale, in order for this to happen. The faculty senate said age discrimination and competency testing must end, and that patients be safeguarded by a process that's the same for all faculty age groups. Well, this overlooks, in my mind, the fact that age really does have associated changes in our physical functioning, hearts, our kidneys, and our brains, and other organs. Anyway, what would be an appropriate policy? It would be very expensive to screen all physicians. That's been tried, as I said, in a couple of provinces in Canada. That would be the fairest, and certainly could be done at all ages, that physicians receive a 360-degree evaluation from their peers and their patients. But in any case, what could be done much more cost effectively is to screen physicians who are referred for concern about competency. This risks getting them at a later stage in their difficulty, but has a much higher yield. And again, should be done at all ages. But when a physician is referred for a concern about competency, a cognitive test should be part of the evaluation. And that would be this level 2 targeted assessment of high-risk individuals. It's important when a flag is raised about a person's competency that they be tested on the types of skills that they're practicing. So, for example, a surgeon should be tested on performance of surgical skills, reaction time, visual spatial skills, and so on. Fortunately, a psychiatrist wouldn't. The targeted assessment is less sensitive but less expensive and more practical. And then we get to the kind of final stage of this, which is we also need programs to help physicians who are cognitively impaired and may no longer be appropriate for normal practice. Maybe there are other things that they can do, but if they've passed beyond subjective cognitive complaints into mild neurocognitive disorder or major neurocognitive disorder, how do we help them? Some individuals may be rehabilitated if they have a remediable condition like a traumatic brain injury, a concussion, a stroke, and some of these people may manage to continue working with a reduced workload or other accommodations, increased time per patient, environmental supports, changes in their documentation, such as learning how to use dictation rather than typing notes and so on, and periodic monitoring. But there are others then who have to be out-counseled. And this is a very delicate function that I haven't seen handled very well in many places, although I have colleagues who have done a great job of it. When a physician has significant cognitive difficulties and should be counseled out of practice, then it's important to include transitioning of their responsibilities in an appropriate way, informing their patients, advising them about financial issues. In the case of the colleague that I mentioned, one of the things that we ended up doing was finding him a guardian ad litem to help him make decisions that he needed to life as he ended his practice. So let me end by saying senior physicians are an important, valued resource and make up a huge part of our healthcare system. But, like all people, are vulnerable to age-associated cognitive changes, which can affect their level of functioning. The assessment of competence of physicians can improve patient safety, but at the risk of infringing on the lives and the rights of these physicians. Assessment of physicians referred because of competence concerns should always include consideration of cognitive functioning and assessment, and a more comprehensive approach has to address factors including patient safety, physicians' rights, and also the practical barriers to help physicians who are leaving practice. I'm going to end with a quote from Dean Griffin, surgeon, 65, who said, "We need to pay attention to these things. I want to reinforce one thing no one else is going to tell you when you are falling back. This has to be something you're conscious of. It may not be time to retire, but the scope of practice is critical for us." So I'll acknowledge that in thinking about this issue, I was very influenced by the wonderful report which you can obtain by the AMA task force. A really good piece of work. But also I had the opportunity to mentor a geriatric psychiatry fellow, Dr. Sun Sawat, who's in Los Angeles now, who has helped me with this, and several other colleagues, including the Senior Physicians Committee of the Massachusetts Medical Society, with whom I've had many fruitful conversations about it. So thank you for your attention, and we can have some discussion if you like.
Jim, that was just really, really wonderful and very enlightening, I think, to all of us. As you pointed out in the beginning of your talk, skills differ over the course of one's life. So people develop trouble with processing rapidly, they may trouble with short-term memory, but their ability to integrate and sort of what you call wisdom, which I think is very real, can continue to improve. So different things are happening in different times. And I think that one of the dangers is that if we use one-size-fits-all testing for people, we may not be able to capitalize on people's very good skills that actually can continue to improve for decades, well into more advanced years. How can we functionally deal with that kind of issue?
Yeah, I think that's a great point. You know, I think, for example, when I was a resident, I had one supervisor who was, at that time, probably in his late 70s, and he was a well-known psychiatrist in Boston. And his knowledge about advances in psychopharmacology or DSM or diagnostic nomenclature and so on were not up to date at all, to the point where we would sometimes be amused, by the deficits in his knowledge. On the other hand, once we saw him sit down with a patient, he could get to the heart of the matter with that person and make a connection that we could only hope that he would learn that skill. And that came from his own personal attributes, but also the years of experience that he had working in the field. So you test something like that. And the model programs that have worked with physicians that are better, I think, have tried to provide a naturalistic practice environment to review the person on the basis of what their own peers in the same profession say, and to try and take into account that a surgeon and a psychiatrist and a primary care practice physician are doing different things. And I'm just restating what but yes, I emphasize that it's important to take into account. And I guess that would be done by presenting, for example, model patients from different types of practices and testing the person on those kinds of patients and having them demonstrate skills that were relevant to.
But even within an area, within a discipline, this is also true. So I can't touch my cardiology fellows' ability to memorize guidelines. I'm not terribly interested in memorizing guidelines, and they have to for the boards. On the other hand, they can't touch me ability to integrate ideas and put them together and see the bigger picture. At least not yet. Don't get.
Yeah. So that's a really interesting comment. Because tonight, as I was kind of doing my last-minute look over of some of the studies that I wanted to talk about here, I looked into one that I hadn't seen for a while that talked very specifically about what are the differences with length of practice between older and younger physicians. And one of the key things that older physicians are rated lower on is adherence to guidelines and memorization of guidelines. And there are an awful lot of guidelines that have come out and that guide various parts of practice, so like emergency contraception counseling, or what to do with certain kinds of intensive emergencies, or and older physicians, the longer they've been out of practice, the less likely they are to know or to follow these guidelines. But on the one hand, that may reflect this, but on the other hand, they may have worked out their own, have merit. That kind of a study, I think, has not been done. Look at patient outcomes as opposed to adherence to guidelines. Other comments? Oh, thank you. Yeah.
One quick one. Myers-Briggs, and you have the various personality assignments there, and basically reflecting people's ability to interpret based on how they're wired. I'm wondering, how do you factor that in to this, or is there a relationship?
Well, it's a great question, and I have no doubt that there's a huge important relationship between personality or character style and how one copes with the changes that occur with aging. For example, and I'm not an expert in this area of research, but I can think of studies that talk about how people with a more obsessive approach tend to have a much harder time with cognitive aging because they're much more conscious of the difficulty. Whereas somebody with a more global or impressionistic cognitive style might maintain that as they get older and feel less. But there must be ways in which thank you so much for your attention today.